11 silent signs of Parkinson's disease most people ignore until it's too late. What if your body has been trying to warn you about Parkinson's disease for months, maybe even years, but you've been dismissing the signals as just normal aging or stress? By the time most people recognize what's happening, they've already missed the critical early window when intervention could make the biggest difference. Here's what most people don't realize. Parkinson's disease affects over 10 million people worldwide, and that number is expected to double by 2040. But here's the crucial part. Research shows that by the time the classic tremor appears, approximately 60 to 80% of the brain's dopamine-producing cells have already been destroyed. That's right, the majority of brain damage happens before the obvious symptoms show up. The Parkinson's Foundation reports that every year, nearly 90,000 people in the United States are diagnosed with this condition. Yet studies reveal that subtle warning signs can appear 5 to 10 years before a formal diagnosis. Now, before you think this doesn't apply to me, consider this. Parkinson's doesn't just affect the elderly. About 4% of people are diagnosed before age 50, and early onset cases are rising. In the next few minutes, I'm going to walk you through 11 silent indicators that medical research has linked to Parkinson's disease, the ones that are easy to ignore but critical to recognize. This video is for educational purposes only and not a substitute for professional medical advice. Always consult a qualified healthcare provider about your health. All information shared is backed by credible, peer-reviewed research with links to the original studies in the description. Now, let's get started with sign 1, bradykinesia. Bradykinesia is a medical term that combines two Greek words meaning slow movement, but it encompasses more than simple slowness. It refers to a progressive reduction in the speed and amplitude of voluntary movements, making everyday tasks increasingly difficult. This isn't the gradual slowing that comes with normal aging. Bradykinesia is a distinct, measurable decrease in movement quality that affects virtually every aspect of physical function. Neurologists consider bradykinesia so fundamental to Parkinson's that both major diagnostic criteria, the UK Brain Bank and the Movement Disorder Society guidelines, require its presence for a definitive diagnosis. Doctors assess it through specific tasks, like asking patients to tap their thumb and index finger together rapidly, make fists repeatedly, or rotate their hands. They're looking for movements that start strong but progressively decrease in size and speed, a phenomenon called the sequence effect. The impact of bradykinesia extends far beyond clinical examination rooms. Patients experience difficulty buttoning shirts, typing on keyboards, or cutting food. Facial expressions become less animated, a condition called hypomimia, which can make people appear sad or uninterested when they're not. Walking becomes slower with shorter steps, and turning around requires multiple small steps instead of a smooth pivot. Recent technological advances have revolutionized how we measure bradykinesia. A 2024 study published in Intelligent Robotics showed that deep learning classifiers trained on motion capture data could differentiate between mild and severe bradykinesia with over 90% accuracy, outperforming traditional clinical assessment. Researchers use inertial measurement units, similar to sophisticated fitness trackers, and digital tablets that record writing pressure and speed. A comprehensive 2025 review in Frontiers in Aging Neuroscience detailed how these tools measure specific parameters, including movement amplitude, speed, range, and rhythm, providing objective data that helps doctors track disease progression and treatment response. Sign 2. Blepharospasm. Your eyelids suddenly squeeze shut with force you cannot control. No amount of willpower stops the involuntary closure. This distressing phenomenon, called blepharospasm, represents a type of focal dystonia that can signal underlying Parkinson's disease. Blepharospasm comes from Greek words meaning eyelid and spasm. It involves forceful, involuntary contractions of the muscles surrounding your eyes. These contractions can be brief twitches or sustained closures lasting seconds to minutes. While relatively rare in typical Parkinson's disease, affecting 0.9 to 3.26% of patients, blepharospasm appears more frequently in atypical Parkinsonism. Progressive supranuclear palsy, a related neurodegenerative condition, shows higher rates of this symptom. This distinction helps neurologists differentiate between various Parkinsonian syndromes. Interestingly, blepharospasm can emerge as a complication of Parkinson's treatment itself. Case reports published in Frontiers in Neurology in 2022 documented patients developing eyelid spasms during peak dose dyskinesia. This occurs when levodopa, the primary Parkinson medication, reaches its highest blood concentration. The timing matters critically for treatment. When blepharospasm appears during medication peaks, it suggests excessive dopaminergic stimulation. And mantidine, a medication that modulates glutamate and dopamine systems, can successfully ameliorate these peak-dose eyelid spasms. Functional MRI studies reveal the brain circuits involved in blepharospasm. These imaging studies show abnormal activity in the basal ganglia, the exact brain structures affected by Parkinson's disease. The cerebellocortical circuits connecting the cerebellum to the outer brain also demonstrate involvement. Some researchers propose blepharospasm might occasionally precede other Parkinson's symptoms. Family case reports and genetic studies suggest this possibility, though the evidence remains controversial. The debate continues about whether isolated blepharospasm represents a true prodromal Parkinson's sign. Treatment options vary depending on blepharospasm's cause and severity. Botulinum toxin injections into the eyelid muscles provide the most effective relief for most patients. Anticholinergic medications and benzodiazepines offer alternatives. For medication-induced cases, adjusting dopaminergic therapy often resolves the problem. Sign 3. Rigidity. Imagine your muscles feeling like they're constantly flexed, creating stiffness that never fully relaxes. Rigidity, affecting up to 89% of Parkinson's patients, creates uniform resistance to passive movement that distinguishes it from other forms of muscle stiffness. Unlike spasticity seen after strokes, which varies with movement speed, Parkinson's rigidity remains constant whether limbs move slowly or quickly. Two distinct patterns characterize Parkinson's rigidity. Lead pipe rigidity creates smooth, uniform resistance throughout the entire range of motion, like bending a lead pipe. Cogwheel rigidity combines this stiffness with underlying tremor, producing a ratchet-like sensation with intermittent catches during passive movement, similar to turning a mechanical gear. Recent groundbreaking research published in Brain in 2023 used robot-assisted biomechanical testing combined with neurophysiological recordings to decode rigidity's mechanisms. Scientists discovered that clinical rigidity severity correlated with abnormal neuronal activity and increased long-latency stretch reflexes, confirming its subcortical origin. These findings explained why rigidity doesn't respond to conscious effort to relax, originating from disrupted signals deep within the brain. Measuring rigidity objectively has challenged clinicians for decades, since traditional assessments rely on subjective feel. A comprehensive review in Sensors from 2020 evaluated portable sensors, myochemometry, and elastography technologies for quantifying muscle stiffness. These devices measure mechanical properties of muscle tissue, providing numerical values rather than subjective ratings, crucial for tracking treatment responses. Sign 4. Resting tremor. The subtle shake in your hand while watching TV might be more than just fatigue. Resting tremor, a rhythmic, involuntary shaking that occurs when muscles are relaxed, affects up to 75% of Parkinson's disease patients and often appears years before diagnosis. This tremor typically oscillates at 4 to 6 cycles per second, creating the characteristic pill rolling motion, where the thumb and forefinger rub together as if rolling a small object. What makes resting tremor particularly distinctive is its behavior pattern. The shaking stops or diminishes significantly when you reach for your coffee cup or perform any voluntary movement. During sleep, the tremor completely disappears, only to return upon waking when your hands are at rest. According to groundbreaking research published in JAMA Neurology in 2022, resting tremor showed an odds ratio of 145.96 in the 2 years before formal Parkinson diagnosis. This means individuals with unexplained resting tremor were nearly 146 times more likely to receive a Parkinson diagnosis within 2 years. The tremor typically begins unilaterally, affecting one hand first, then potentially spreading to the opposite side as the disease progresses. Recent technological advances have revolutionized tremor detection and analysis. A 2023 study in BMC Neurology demonstrated that EEG features combined with accelerometry could predict resting tremor onset with 73.7% accuracy. These tools measure brain electrical activity and movement patterns simultaneously, providing objective data beyond visual observation. The emotional impact of visible tremor often drives patients to seek medical attention earlier than those with other symptoms. This visibility, while distressing, can actually lead to earlier diagnosis and intervention, potentially slowing disease progression through timely treatment initiation. Sign 5. Postural instability. Balance problems in Parkinson's disease go far beyond occasional stumbles. Postural instability represents a fundamental breakdown in the complex systems maintaining upright stance, affecting up to 68% of patients within 5 years of diagnosis. This symptom transforms simple activities like reaching for high shelves or navigating crowded spaces into potentially dangerous challenges. The brain's balance control involves intricate coordination between the cerebellum, basal ganglia, and brainstem, with input from vision, inner ear, and proprioception sensors throughout the body. Parkinson's disrupts these circuits, impairing automatic postural adjustments that healthy individuals make unconsciously. Research from Brain Sciences in 2023 demonstrated clear instability in both static standing and dynamic movement conditions as the disease advances. Clinical testing uses the pull test, where examiners suddenly pull patients backward by the shoulders. Healthy individuals take 1 or 2 steps to recover balance, while those with postural instability require multiple steps or would fall without assistance. However, this test only captures one aspect of a multifaceted problem affecting anticipatory adjustments, reactive responses, and sensory integration. A large cohort study published in Journal of Clinical Medicine in 2023 revealed disturbing statistics about fall risk. Patients with disease duration exceeding 5 years showed exponentially increased fall rates, with some experiencing multiple falls weekly. These falls often result in fractures, head injuries, and psychological consequences, including fear of falling that further limits mobility. Cognitive deficits, particularly in executive function, compound postural instability, according to research from the Journal of Parkinson's Disease. When the brain struggles with dual tasking, like walking while conversing, automatic balance corrections fail. Understanding these connections helps explain why seemingly simple distractions can trigger devastating falls in advanced Parkinson's disease. Sign 6. Olfactory dysfunction. Years before the first tremor appears, up to 90% of future Parkinson's patients lose their sense of smell. Hyposmia, the medical term for reduced smell sensitivity, often develops so gradually that patients don't notice until directly tested. This silent symptom provides one of the earliest windows into neurodegeneration, sometimes preceding motor symptoms by a decade. The olfactory system's vulnerability stems from its direct exposure to environmental toxins and unique position as an entry point for pathological proteins. Alpha-synuclein, the misfolded protein central to Parkinson's pathology, accumulates in olfactory bulbs before spreading to other brain regions. Research from Frontiers in Neuroscience in 2020 demonstrated that synucleinopathy density in olfactory structures correlates with motor symptom severity scores. Standardized smell tests like the University of Pennsylvania Smell Identification Test, UPSIT, can predict future neurodegeneration with remarkable accuracy. A longitudinal study published in the Journal of Neurology in 2025 followed patients for 10 years, finding that poor olfactory scores predicted not just Parkinson's diagnosis, but also cognitive decline trajectory and semantic fluency deterioration. These findings position smell testing as a powerful screening tool. The mechanism involves more than simple sensory loss. Olfactory dysfunction reflects fundamental disruption in neural networks processing smell information, with pathology extending from peripheral receptors through central processing centers. This explains why patients don't just smell less intensely, but often misidentify odors or experience phantom smells. Recognizing olfactory dysfunction's significance changes how we approach early detection. Combined with other biomarkers, smell testing could identify at-risk individuals years before irreversible neuronal loss occurs.
Sign 7. Upper airway obstruction. A terrifying complication hiding in plain sight, upper airway obstruction affects between 6.7% and 67% of Parkinson's patients, depending on assessment method. This potentially life-threatening condition manifests as difficulty breathing, noisy breathing called stridor, or sudden airway closure requiring emergency intervention. Despite its severity, many healthcare providers remain unaware of this Parkinson's complication. The pathophysiology mirrors the disease's effects on limb muscles, but involves the throat and larynx. Rigidity and bradykinesia affect upper airway muscles, causing abnormal glottic movements and vocal cord dysfunction. A landmark case report from Anesthesia and Intensive Care in 1995 documented repeated airway obstruction episodes when levodopa was withdrawn, completely reversible with medication reinstitution. Flow volume loop studies reveal characteristic patterns in affected patients, including respiratory flutter matching tremor frequency and irregular glottic movements. Direct laryngoscopy often shows paradoxical vocal cord movement, where cords close during inhalation rather than opening. These findings confirm that upper airway muscles experience the same movement disorders affecting other body parts. Risk escalates dramatically during specific circumstances. Perioperative periods when medications are held, severe off periods with maximum rigidity, and advanced disease stages all increase obstruction likelihood. Some patients experience nocturnal stridor, a harsh breathing sound that disrupts sleep and may progress to daytime symptoms. Recognition saves lives, since standard interventions for breathing difficulties may prove ineffective. Maintaining dopaminergic therapy even during surgical procedures, using alternative delivery methods when oral medications aren't possible, becomes critical.
Sign 8. Micrographia. Your signature keeps shrinking. Each word you write becomes progressively smaller and more cramped until the letters become nearly illegible. This distinctive handwriting change, called micrographia, frequently announces Parkinson's disease before other symptoms become apparent. Micrographia literally means small writing in Greek. It manifests as abnormally tiny, cramped handwriting resulting from the same bradykinesia affecting other movements. But micrographia involves more than just writing small letters from the start. The characteristic pattern involves progressive shrinkage. Your first few words might appear relatively normal in size. As you continue writing across the page or down a list, each subsequent word becomes smaller. By the end of a sentence, your writing might be half the original size. A 2019 study published in Frontiers in Neurology quantified this progression precisely. Researchers found that 66% of Parkinson's patients exhibited progressive micrographia, defined as greater than 10% reduction in letter stroke length during repetitive writing tasks. This specific measurement provides objective criteria replacing subjective assessment. The study employed digital tablets that record not just the final written product, but the entire writing process. These devices measure pen pressure, stroke velocity, acceleration, and timing,
This kinematic analysis reveals motor control problems invisible in the finished handwriting sample. Researchers discovered that micrographia closely parallels the sequence effect characteristic of bradykinesia. Each repetitive movement becomes smaller and slower than the previous one. Writing demonstrates this pattern as poorly sustained net force generation and diminished pen tip pressure. What makes these findings particularly interesting is their independence from overall motor disability. Micrographia severity doesn't necessarily correlate with total UPDRS-3 bradykinesia scores. Someone might have relatively mild limb bradykinesia, but severe micrographia, or vice versa. This dissociation suggests different neural circuits control different motor tasks. The brain regions governing fine motor control of handwriting may be affected differently than those controlling gross limb movements. This specificity makes micrographia a distinct and valuable clinical marker.
Sign 9. Constipation. Constipation might seem like an unrelated digestive complaint, but it's actually a common and sometimes prodromal symptom of Parkinson's disease. Prodromal means it can appear before motor symptoms, sometimes by many years. Prevalence estimates range from 30 to 70% of Parkinson's patients, making it one of the most frequent non-motor symptoms. A comprehensive systematic review and meta-analysis published in European Neurology in 2023 quantified the relationship between constipation and Parkinson's risk. Researchers calculated a pooled odds ratio of 2.36, meaning people with constipation were more than twice as likely to eventually develop Parkinson's disease compared to those without constipation. Remarkably, constipation can precede a Parkinson's diagnosis by up to 10 years, representing one of the longest prodromal periods of any symptom. The biological explanation involves both the central nervous system and the enteric nervous system, sometimes called the second brain, because of its extensive network of neurons controlling digestive function. Alpha-synuclein deposits, the hallmark pathology of Parkinson's, have been found in the submucosal and myenteric plexus, the nerve networks embedded in intestinal walls. Some researchers propose that Parkinson's pathology might actually begin in the gut and spread to the brain via the vagus nerve, though this remains controversial. Research published in Frontiers in Neurology in 2019 demonstrated that constipation significantly impacts quality of life and correlates with reduced physical activity, advanced disease stage, and higher disability scale scores. Importantly, constipation doesn't necessarily respond to dopaminergic medications that improve motor symptoms, indicating different underlying mechanisms. In fact, anticholinergic medications, sometimes used for tremor, can worsen constipation. These findings establish constipation as a critical non-motor marker relevant for early screening, and managing it requires dedicated attention separate from motor symptom treatment.
Sign 10. Cognitive impairment. You forget words mid-sentence. Planning simple tasks becomes overwhelming. Spatial relationships confuse you when they never did before. These cognitive changes, ranging from subtle difficulties to profound dementia, affect the majority of Parkinson's patients during their disease course. Cognitive impairment in Parkinson's exists along a spectrum. At the mild end, patients experience subjective cognitive complaints, noticing difficulties that don't show up on formal testing. Mild cognitive impairment, abbreviated MCI, involves measurable deficits that don't significantly impact daily independence. At the severe end lies Parkinson's disease dementia, or PDD. This condition involves cognitive decline severe enough to impair daily functioning and independence. Meta-analyses across 41 studies involving 7,053 participants revealed concerning statistics about cognitive decline's prevalence. Approximately 30 to 40% of newly diagnosed Parkinson's patients already have mild cognitive impairment at diagnosis. This finding surprises many people who think of Parkinson's as purely a movement disorder. Even before treatment begins, cognitive changes are detectable in a substantial minority. The prevalence increases relentlessly with disease duration. After 10 years, about 75% of patients have developed measurable cognitive impairment. Over a lifetime with Parkinson's, the cumulative prevalence of dementia reaches 80%. Cognitive impairment can actually precede Parkinson's motor diagnosis by several years. Early deficits typically involve attention, executive function, and visuospatial abilities. Executive function encompasses planning, organizing, multitasking, and mental flexibility. Visuospatial abilities involve understanding spatial relationships and navigating environments. The Movement Disorders Society Task Force established diagnostic criteria for Parkinson's-related mild cognitive impairment. These criteria require objective deficits on neuropsychological testing without significant loss of independence in daily activities. This distinction separates MCI from dementia. Longitudinal studies identify specific risk factors predicting faster cognitive decline. Depression increases dementia risk substantially. More severe motor symptoms correlate with worse cognitive outcomes. Specific genetic variants in genes like SNCA, LRRK2, and GBA confer higher risk.
Sign 11. REM sleep behavior disorder. REM sleep behavior disorder, commonly abbreviated RBD, involves acting out vivid, often violent dreams during REM sleep, the stage when most dreaming occurs. Normally during REM sleep, the brain paralyzes most voluntary muscles, preventing dream enactment. In RBD, this protective paralysis fails, allowing people to punch, kick, leap from bed, or run, potentially injuring themselves or bed partners. The prevalence and significance of RBD in Parkinson's disease is remarkable. Estimates suggest 25% of patients have RBD at diagnosis, increasing to over 50% as disease advances, according to longitudinal data published in Current Neurology and Neuroscience Reports, BMC Medicine, and NPJ Parkinson's disease between 2021 and 2024. Even more striking, RBD often precedes other Parkinson's symptoms by years or even decades. RBD's predictive power for synucleinopathies, the family of diseases including Parkinson's characterized by alpha-synuclein accumulation, is extraordinary. A multi-center study published in Current Neurology and Neuroscience Reports in 2022 showed phenoconversion rates, meaning progression from isolated RBD to a diagnosed synucleinopathy, reached 73% at 12 years after idiopathic RBD onset. This means nearly 3/4 of people with isolated RBD eventually develop Parkinson's or a related condition. Imaging and neuropathological studies reveal that RBD patients already have established brainstem and peripheral autonomic nervous system involvement equivalent to early-stage Parkinson's. The presence of RBD predicts more aggressive disease, with higher risks for hallucinations, dementia, autonomic dysfunction, and faster motor progression. These convergent findings establish RBD as perhaps the most sensitive and specific early biomarker for Parkinson's-related neurodegeneration. For people with isolated RBD, close monitoring and eventual neuroprotective treatments, once available, could potentially delay or prevent Parkinson's onset.
Thanks so much for watching. If you found this video helpful, please give it a like, and don't forget to subscribe for more science-backed health insights. Your support really helps us bring you more valuable content.